السلام عليكم.
عليكم السلام ورحمة الله.
Good afternoon, everyone, and welcome to our weekly academic activity. So today we'll start our mitral valve section, and we have two lectures today. First one by Dr. Riyad Al-Harthi about anatomy and pathophysiology of mitral valve disease, and the second about the latest mitral valve guidelines by Dr. Khalid Gharni. We are glad to have Dr. Hassan Sabban, who is a cardiac surgery consultant at King Fahd Military Hospital, to join us in this session. So I believe we can start in 5 minutes. Dr. Riyad, you can prepare your slides. Dr. Riyad.
Assalamu alaikum.
Assalam wa rahmatullah. You can start. Thank you.
Assalamu alaikum. Riyad Al-Harthi, cardiac surgery resident at Kafafa. I will talk about anatomy and pathophysiology of mitral disease. Anatomy: the mitral annulus, fibrous and muscular tissue that join the left atrium and left ventricle portion of the anterior and posterior mitral leaflet. Two major collagens structure the right fibrous trigon, which located at the intersection of membranous septum, the tricuspid annulus, and aortic annulus. The left fibrous trigon, which is located near the aortic annulus under the left aortic cusp. The mitral valve has two major leaflets, the larger anterior leaflet and smaller posterior leaflet. The latter usually contain three or more scallops separated by fatal cleft or subcommissions. The anterior leaflet is direct fibrous continue with aortic annulus. Posterior leaflet is primary muscular with little or no fibrous tissue. The three posterior leaflet scallops are termed anterolateral, middle, and posteromedial scallops. The portion of leaflet near free margin on the atrial surface are called rough zone, with the remainder of leaflet surface closer to the annulus being termed smooth zone. The two leaflets are separated by posteromedial and anterolateral commissures. The histological structure of the leaflet includes three layers. Fibrosa, solid collagen are continued with the chordae tendineae, spongiosa on the atrial surface and form leaflet leading edge. A thin fibroelastic covering the most of the leaflet. Mitral leaflet contain myocardium, smooth muscle, contractile valvular interstitial cell, and blood vessels, as well as both adrenergic and cholinergic afferent and efferent nerves. Leaflet contractile tissue is neurally controlled. Annular size. The average mitral annular cross-section area average is 7.6 centimeters. Posterior annulus circumscribe approximately 2/3 of mitral annulus. Maximal annular area occur in late diastole. The highest point farthest from LV apex located anterior and middle of the anterior leaflet. This portion is termed saddle horn by surgeon. The low point are located posteromedial and anterolateral in the commissures. The mitral annulus move upward into the left atrium is in diastole and toward an LV apex during systole. Dynamic leaflet motion. The posterior mitral leaflet is attached to thinner chordae tendon than the anterior leaflet. The leaflet edge is middle valve appear to separate before this portion closer to the commissures. Early leaflet opening E wave is very rapid once reaching maximum opening. The edge like flag flapping in breeze until another less forceful opening impulse occur associated with the E wave. Valve closure starts with leaflet bulging toward the atrium at its attachment point to annulus. The closure rate of the anterior leaflet is almost twice that posterior leaflet. Chordae tendineae and papillary muscle. Epicardial fibrous in the left ventricle descend from base of the heart and proceed inward at the apex to form the two papillary muscle. The anterolateral papillary muscle usually has one major head and is more prominent structure. The posteromedial papillary muscle have two or more subhead and is flatter. The posteromedial papillary muscle usually supplied by right coronary artery. The anterolateral papillary muscle supplied by LAD and circumflex artery. Posteromedial and anterolateral papillary muscle give rise to chordae tendineae going to both leaflets. The chordae are divided functionally into three groups. First order chordae originate near the papillary muscle tips, divide progressive and insert on the leading edge of the leaflet. These primary chordae prevent valve edge prolapse during systole. Second order chordae originate from the same location and tend to be thicker and fewer in number. They are more important for optimal ventricular systolic function. The order cordary originates directly from trabeculae cornea of the ventricular wall attached to the posterior leaflet near to the annulus and can be identified by their fan-shaped pattern. In total, about 25 major chordal trunk rise from papillary muscle in human. During diastole, the papillary muscle form inflow tract. During systole, create an outflow tract. The contribution of papillary muscle to LV chamber volume is 5 to 8% during diastole, but 15 to 30% during systole. The anterolateral and posteromedial papillary muscle contract simultaneously and are inverted by vagal nerve. The leaflet in the closed valve are virtually self-support. Mitral stenosis. Etiology, rheumatic heart disease, sphere mitral calcification in elderly, congenital mitral valve deformity, malignant carcinoid syndrome, LA thrombus, endocardiac vegetation. Hemodynamic, the average LA pressure in patients with severe mitral stenosis may be in the range of 15 to 20 millimeter per mercury at rest with mean transvalvular gradient of 10 to 15 millimeter. A high transvalvular gradient may be associated with normal cardiac output. The development of AF decreased cardiac output by 20%. Ventricular adaptation, LV end diastolic volume is normal or smaller than normal, and end diastolic pressure typically is low. The peak filling rate is reduced as stroke volume. Cardiac output is diminished during exercise, and LV ejection fraction may increase slightly. Approximately 25 to 50% patients with severe mitral stenosis have LV systolic dysfunction. LV in systolic and diastolic volume may be larger than normal. Right ventricular afterload increase as pulmonary hypertension. Atrial adaptation, elevated mean LA pressure with prominent A wave, LA hypertrophy and dilatation, AF and atrial thrombus formation, premature atrial activation, increased automaticity may lead to atrial fibrillation. Pulmonary change, LA hypertension produces pulmonary vasoconstriction, which exacerbates the elevated pulmonary vascular resistance. Pulmonary hypertension worsens progressive, leading to right side heart failure, tricuspid insufficiency. In the clinical evaluation, patients become asymptomatic for many years. Pulmonary venous congestion or low cardiac output, for example, dyspnea or dyspnea, BND, and fatigue. Pulmonary hypertension and right side heart failure, sign of tricuspid regurgitation, hepatomegaly, peripheral edema, ascites. Hemoptysis secondary to rupture of dilated bronchial vein, acute pulmonary edema with pink frothy sputum, systemic thromboembolism occurring in 20% of patients. If an episode systemic embolization, infective endocarditis should be considered. Patients with chronic mitral stenosis are often thin and frail. Heart size usually is normal. Osculatory finding, presystolic murmur, loud S1, opening snap, apical diastolic pimple, S2 become prominent. In the chest radiograph, LA enlargement, double contour of right heart border, elevation of left main stem bronchus, prominence pulmonary artery, pulmonary lymphatic are seen, horizontal linear obesity in lower length field, curly P line. In electro, it's not accurate to assess, but we can see LA enlargement, atrial arrhythmia are common, and right ventricular hypertrophy. In the echo, it's primary diagnostic method for assessing mitral valve pathology and pathophysiology. Cross-sectional valve area, LA, and LV dimension can be quantified using 2D transthoracic echocardiography. Parasternal long axis view features of rheumatic mitral stenosis include reduced diastolic expression of the leaflet, Carpentier type 3 leaflet motion, and thickening or calcification of valvular and subvalvular apparatus. 3D echo facilitates spatial recognition of intracardiac structure and can be evaluate cardiac, valvular, and congenital heart disease using both real-time 3D TTA and TA images. In-mode finding include thickening, reduced motion, and parallel movement of the anterior and posterior leaflet during diastole. Doppler echocardiography determine peak and mean transvalvular mitral pressure to estimate mitral valve area pressure half time. TEE is better than transthoracic approach for visualizing details of valvular pathology such as valve mobility and thickness, subvalvular apparatus involvement, and extent of leaflet or chemical calcification. Cardiac MRI remain inferior echo for demarcation valve morphology and motion. Multidictor CT may emerge as technique that can be evaluate both cardiac structure and function. Cardiac catheterization is not necessary to establish diagnosis of mitral. It provides information regarding coronary status in older patients. Left side heart catheterization allow determine LV in diastolic pressure, and right side performed measure cardiac index and degree of pulmonary hypertension. Post-procedure outcome, 90% of patients improve clinically evolve area greater than 1.5 centimeter without significant regurgitation can be achieved. Surgical intervention improve functional capacity and long-term survival of patients with mitral stenosis. 67 to 90% of patients are alive at 10 years. Mitral regurgitation, etiology, it's myxomatous degeneration, primary mitral regurgitation, ischemic mitral regurgitation, dilated cardiomyopathy, which now functional mitral regurgitation, rheumatic valve disease, mitral annular calcification, infective endocarditis, congenital anomaly, acute mitral regurgitation such as Takotsubo. 4 types of structural change of mitral valve may produce regurgitation. Leaflet retraction from fibrosis and calcification, annular dilatation, chordal abnormality, LV systolic dysfunction with or without papillary muscle involvement. Carbonaceous calcified mitral regurgitation according to 3 main pathoanatomic types based on mitral leaflet motion. Normal leaflet motion type 1, leaflet prolapse or excessive motion type 2, restricted leaflet motion type 3. Type 3 is subdivided into type 3A and type 3P based on leaflet restriction during diastole type 3A as seen rheumatic disease or during systole type 3B, which typically seen in IMR. Myxomatous degeneration, most common cause, mitral regurgitation in patient associated with connective tissue. Mitral valve prolapse appear to be more widespread in women, but severe more common in men. Sign of heart failure usually manifest as decline stamina and fatigue. Parallel syndrome include prolapse of posterior leaflet, chest pain, and actually palpitation, syncope and dyspnea in younger patients. Beta adrenergic receptor polymorphism may play role in pathogenesis of symptoms. Myxomatous degeneration commonly involve annulus resettling and annular thickening and dilatation. Only 5 to 10% patients with mitral valve prolapse progress to develop severe mitral regurgitation, and they can remain relatively asymptomatic for many years. Mechanism accounting for severe mitral regurgitation include annular dilatation and rupture or elongation of the first order chordary, 58%, annular dilatation without chordal rupture without annular dilatation, both of them 19%, chordal rupture probably related to defective collagen. Functional and ischemic mitral regurgitation, functional FMR termed secondary mitral regurgitation associated with long-standing mitral regurgitation caused by severe chronic LV volume overload. Most commonly, the etiology of non-ischemic cardiomyopathy is unknown or idiopathic. 15% of patients with anterior wall involvement and up to 40% of patients with an inferior infarct. The pathophysiology of IMR change in global and regional LV function or geometry, attention in mitral annular geometry, abnormal leaflet motion, malcoaptation. Annular geometry. In IMR, increase mitral annular area, annular stretching and flattening, increase septal lateral annular dimension, LV dilatation and larger annular dimension after inferior myocardial infarction. Sudden shape of normal annulus which become exudated during systole. Anterior and posterior annular increase are combined by increased interregional annular distance and restriction of annular motion. Leaflet motion and morphology. Acute IMR, delayed valve closure, early systole, and increased leaflet edge separation. There is lateral displacement of central scallop of posterior leaflet. In the chronic IMR, posterior leaflet displacement in posterior direction and lateral displacement in both leaflet. IMR and FMR, there is growth or elongation of leaflet associated with leaflet thickening. Anterior mitral leaflet strip from falling heart 50 to 61% stiffer and less viscous. Papillary muscle and chordal relationship. The papillary annular distance in the LV long axis remain constant. IMR, the intrapapillary distance and LV end diastolic volume both increase. Posteromedial papillary muscle tip displacement and anterolateral papillary muscle depth and papillary muscle angle decrease. Papillary muscle ischemia and rupture. Papillary muscle necrosis can complicate myocardial infarction. Frank rupture of papillary muscle is rare. Total papillary muscle rupture usually is fatal. Papillary muscle rupture usually occurs 2 to 7 days after myocardial infarction. Without emergency operation, approximately 50 to 75% such patient may die within 24 hours. Rheumatic disease remain the most common mitral regurgitation. The pathoanatomical change of regurgitation of rheumatic valve different from those with stenotic valve. In chronic rheumatic mitral regurgitation, the valve have diffuse fibrous thickening of leaflet with minimal calcific deposit. Shortening of chordal tendon, fibrous infiltration of the papillary muscle, asymmetric annular dilatation. Anterior leaflet prolapse tend to improve with medical management. Posterior leaflet have less favorable outcome and often require early surgical. Mitral annular calcification, it's in the older age than 60 years of age. Women are affected more than men. The pathogenesis of mitral annular calcification is not known. The gross appearance of calcification may vary from small, localized, classified speculous to massive, frigid, crescentic pulse. Calcification begin at mid-portion of the posterior annulus. Leaflet become upward deformed, stretching, and chordae tendon. The calcific deposit spurs extend into LV myocardium and the conduction system. Annular calcification causes mitral regurgitation by displacing and immobilizing the mitral leaflet. Clinical evaluation, asymptomatic for many years, gradually weakness, fatigue, palpitation, dyspnea, exertion. If right side heart failure, hepatomegaly, peripheral edema, ascites. In physical examination, S1 diminished, widely split S2, S3 gallop may be appreciated. The apical systolic murmur can be blowing, moderately harsh, soft, usually radiate to axilla and left or right sternal border and occasionally to the neck or vertebral column. In younger patients with parlous valve, characteristic mid-systolic click is heard followed by a late systolic murmur often become holosystolic and mid-systolic click may become inaudible. In chest radiograph, cardiomegaly found commonly in patients with long-standing moderate to severe mitral regurgitation. Interstitial edema is seen frequently in individuals with acute mitral regurgitation. Electrocardiogram not particularly useful. Atrial fibrillation can occur, LA and LV dilatation, and eventually to LV hypertrophy. Atrial arrhythmia may be present in upward 14% of patients, and ventricular arrhythmia are present in 30%. TTA is diagnostic mainstay, chronic mitral regurgitation, flow progression of LA and LV dilatation. Echocardiography identify abnormality of the leaflet, chordal morphology and function. The degree of mitral regurgitation is assessed using 2D color Doppler echo. Chordal rupture or elongation causing a flyal leaflet is characterized by excessive motion of the leaflet backward into left atrium beyond normal leaflet coaptation zone. Papillary muscle rupture after myocardial infarction and annular dilatation can be visualized. Patient with IMR or FMR, apical systolic tethering of leaflet, tending area height, and leaflet opening angle can be quite quantitated using echocardiography. Accurate quantification of the degree of mitral regurgitation using ERO or regurgitant. 3D echocardiography helpful in patient visual assessment, congenital and acquired valvular disease. 3D color Doppler provide direct measurement of vena contracta area. MRI, accurate method for measurement regurgitant of the volume and fraction. CT, imaging technique that can fully evaluate both cardiac structure and function. Catheterization only in older patient before repair or with IMR. Right side catheterization to identify pulmonary hypertension. Postoperative LV function and surgical outcome, clinically improvement, augmented forward stroke volume with lower total stroke volume, smaller LV in diastolic volume, and regression of LV hypertrophy. Preserve LV contractility. Patient with LV dysfunction, preoperative improvement in LV systolic function may not necessarily occur after operation. Patient generally reports symptomatic improvement. Cardiopulmonary exercise testing at 7 months may not be better than preoperative. Abnormal neurohumoral activation persists, probably reflective of incomplete recovery LV contractility. Regarding long-term clinical outcome, risk factor post-operative cardiac deterioration include larger LV in diastolic dimension, increase the left ventricular end systolic diameter and volume. The diminished fractional shortening, large LA size, decrease LV wall thickness. And this is my reference. Thank you.
Thank you, Riyad. Dr. Hassan. Didn't know Dr. Hassan is still with us. I think he left. So any question for Riyad? So we'll have a break for 5 minutes and then we'll come back for the second lecture. Thank you. دكتور خالد. تفضل.
Assalamu alaikum, good afternoon everyone. Today we'll talk inshallah about the newest mitral valve guidelines 2020 released last month by the American Heart Association, American College of Cardiology collaboration. So to start with, this is just a reminder for the class of recommendation ranging from class 1 with a strong strength of recommendation to class 2A with a moderate strength of recommendation where the benefit is still higher than the risk of the intervention being used. Class 2B with slightly weak strength of recommendation with the benefit being more than or equal to risk. Class 3 divided to two classes with no benefit where the benefit equal risk, or class 3 with harm where the risk is higher than the benefit. For level of evidence, we have level A, B, and C. It represents the quality of evidence. Level A usually comes from a meta-analysis of high-quality RCTs or high-quality evidence from more than one RCT. Level B, we have BR and NR. BR comes from randomized RCTs and NR from observational studies or meta-analysis of such studies. Level C, LD, the evidence comes from limited data, and EO from expert opinion. So general principles to start with. Usually, for evaluation of patients with known or suspected valvular heart disease, the standard initial diagnostic test in the initial evaluation of patients is the transthoracic echo to establish the chamber size and function, valve morphology and severity, and the effect of pulmonary and systemic circuits. History and physical, it's important to establish symptom severity, comorbidities, valve disease presence and severity, and presence of heart failure. ECG, it's important to establish the rhythm, LV function, and presence and absence of hypertrophy. Chest X-ray for symptomatic patient to establish heart size and presence or absence of pulmonary vascular congestion, intrinsic lung disease, and calcification of aorta and pericardium. Transesophageal echo, it provides high-quality assessment of mitral and prosthetic valve, including definition of intracardiac masses and possible associated abnormalities like intracardiac abscesses or LA thrombus. Cardiac MRI provides assessment of LV volumes and function and valve severity and aortic disease assessment. PET-CT aids in determining an active infection or inflammation. Stress testing gives an objective measure of exercise capacity. Cath provides measurement of intracardiac and pulmonary pressure, valve severity, and hemodynamic response to exercise and drug. Serum biomarkers provides indirect assessment of filling pressures and myocardial damage. Transthoracic echo with strain help assess intrinsic myocardial performance, and cardiac MRI also assess fibrosis by gadolinium enhancement. Stress testing provides prognostic markers and procedural risk assessment quantified by STS risk score to predict the mortality risk, and frailty score. It provides assessment of risk for the procedure and chance of recovery of quality of life for patients. So we usually use a combination of these test in assessing and evaluating patients with known or suspected valvular heart disease. Prior to valve intervention, we do dental examination to rule out potential infection sources. CT coronary angio or invasive coronary angiogram provides an assessment of coronary anatomy, usually CT angio for low to intermediate pretest probability for coronary artery disease. CT peripheral to assess accesses for transcatheter procedures, and cardiac CT to assess suitability for transcatheter procedures. We have 4 stages for valvular heart disease from A to D. A being at risk, B progressive, C asymptomatic, C1 and C2, classified into C1 and C2. C1 when we have compensated LV, C2 when we reach the level of decompensation, stage D when we reach severe symptomatic stage. For diagnosis and follow-up, for stage B mitral stenosis, usually the frequency of echocardiogram in asymptomatic stage B every 3 to 5 years when we have the mitral valve area more than 1.5 centimeters square. For MR, stage B MR, usually every 3 to 5 years as well for mild severity, and every 1 to 2 years for moderate severity. For stage C1, severe symptomatic MS, they follow up usually every 1 to 2 years when we have the mitral valve area 1 to 1.5, and every year when we have mitral valve area less than 1. And for MR, every 6 to 12 months for stage C1, severe asymptomatic MR. And when we have a dilated LV, will require more frequent echocardiogram follow-up. Some principles of medical therapy in patients with AF and valvular heart disease. For patients with atrial fibrillation and native valve heart disease, except rheumatic MS, or who received a bioprosthetic valve more than 3 months ago, a non-vitamin K oral anticoagulant, the new NOAC, is an effective alternative to vitamin K anticoagulation and should be administered on the basis of patients' SHAD-VAS score. This is a class 1 level A recommendation. For patients with AF and rheumatic MS, long-term vitamin K antagonist oral anticoagulation is recommended, class 1. For patients with new onset AF, 3 or less than or equal to 3 months after surgical or transcatheter bioprosthetic valve replacement, anticoagulation with a vitamin K antagonist is reasonable. That's class 2A, level B. But in patients with a mechanical heart valve with or without AF who require long-term anticoagulation with vitamin K antagonists to prevent valve thrombosis, the NOACs still not recommended, class 3, harmful. This is just a diagram to summarize the anticoagulation for AF in patients with valvular heart disease. Rheumatic MS, still with vitamin K antagonist, and for mechanical prosthesis, we'll go with anticoagulation with vitamin K antagonist as well. So nothing was changed. Evaluation of surgical and interventional risk. For patients with valvular heart disease for whom intervention is contemplated, individual risk should be calculated for specific surgical and or transcatheter procedures using online tools when available, and discussed before the procedure as a part of a shared decision-making process. That's a class 1 recommendation. For risk assessment of surgical valve procedures, we have 4 criteria. STS score for mortality risk assessment, frailty scores with 7 different indices to categorize patients with no frailty, mild, moderate, and severe frailty, cardiac or other major organ system compromise, and procedure-specific impediment. So for low-risk surgical AVR must meet all these criteria, less than 3% in STS mortality risk score, and no frailty, no cardiac or major organ systemic compromise, and no procedure-specific impediment. This is new in the latest guidelines. Low-risk surgical mitral valve repair for primary MR. It must meet all these criteria in this column, less than 1% mortality predicted by STS score, and no frailty and no cardiac or other organ system compromise, and no procedure-specific impediment. For high surgical, there's no intermediate like in the previous guidelines. For high surgical risk, any one criteria in this column, so higher than 8% mortality predicted by STS score, 2 or more indices in the frailty risk assessment score, 1 to 2 organ systems dysfunction, and possible procedure-specific impediment. For prohibitive surgical risk, any one criteria, either predicted risk of death or major morbidity for all cause, more than 50% at 1 year, 2 or more indices indicate moderate to severe frailty, and 3 or more organ system dysfunction and severe procedure-specific impediment. That's indicate a prohibitive surgical risk. The role of multidisciplinary heart valve team and the heart valve centers. The patient with severe valvular heart disease should be evaluated by a multidisciplinary team when intervention is considered. That's class 1A. A consultation with or referral to a primary or comprehensive heart valve center is reasonable when treatment options are being discussed for asymptomatic patients with severe valvular heart disease or patients who may benefit from valve repair versus valve replacement, or patients with multiple comorbidities for whom valve intervention is considered. That's class 2A, level C. So for periodic imaging after valve intervention in asymptomatic patients with any type of valve intervention, a baseline post-operative transthoracic echo followed by a periodic monitoring with a transthoracic echo is recommended depending on type of intervention, length of time since intervention, and ventricular function and concurrent cardiac condition. That's class 1. For different valve interventions and minimal imaging frequencies, for example, mechanical valve, we should have a baseline echo at the primary valve center. Bioprosthetic valve, surgically, we should have a baseline echo 5 and 10 years after surgery, and then annually. And these numbers are subjected to change if we have, for example, development of new signs or symptoms, younger age at the surgical implantation of bioprosthetic valve, etc. Transcatheter bioprosthetic valve, we should have a baseline echo and then annually at the primary valve center. For mitral valve repair, surgically, we should have a baseline 1 year and then every 2 to 3 years. For mitral valve repair transcatheter, we should have a baseline and then annually echo at the comprehensive valve center. So moving to mitral stenosis. Like we said, we have 4 stages of valvular heart disease. Stage 1 MS, when we have patients at risk of mitral stenosis, with valve anatomy being mild valve dooming during diastole, and normal transmitral flow velocity at the level of the valve hemodynamics, with no hemodynamic consequences and no symptoms. Stage B, when we have progressive mitral stenosis, the valve anatomy usually rheumatic changes with commissural fusion and diastolic doming of the mitral valve leaflets, with a mitral valve area by planimetry more than 1.5 centimeters square. The effect on valve hemodynamics, usually with increased transmitral flow velocities and mitral valve area more than 1.5, diastolic pressure half time less than 150 millisecond. And that will lead to mild to moderate LA enlargement with normal pulmonary pressure at rest, and still patient doesn't have any symptoms. Stage C, when we have asymptomatic severe MS, the valve anatomy, similar to the previous one, rheumatic valve changes with commissural fusion and diastolic doming of the mitral valve leaflets, and mitral valve area by planimetry equal or less than 1.5 centimeters square, and diastolic pressure half time more than or equal to 150 millisecond. But we have severe LA enlargement and elevated pulmonary artery systolic pressure more than 50 millimeter mercury with no symptoms. Stage D, when we have symptomatic severe MS, same valve anatomy, rheumatic valve changes with commissural fusion and diastolic doming of the mitral leaflets, and the mitral valve area less than or equal to 1.5 centimeters square, and diastolic pressure half time more than or equal 150 millisecond, with severe LA enlargement and elevated pulmonary artery systolic pressure more than 50, with development of symptoms related to decreased exercise intolerance and exertional dyspnea. For initial diagnosis for rheumatic MS, in patients with signs or symptoms of rheumatic MS, transthoracic echo is indicated to establish the diagnosis, quality, or quantify, the hemodynamic severity, assess concomitant valvular lesions, and demonstrate valve morphology to determine suitability for mitral commissurotomy. That's class 1. In patients considered for percutaneous mitral balloon commissurotomy, the transesophageal echo should be performed to assess the presence or absence of LA thrombus and to evaluate the severity of MR to assess the stability for such intervention. That's class 1. In patients with rheumatic MS and discrepancy between the resting echo finding and clinical symptoms, exercise testing with Doppler or invasive hemodynamic assessment is recommended to evaluate symptomatic response and the exercise capacity and response to the mean mitral gradient and pulmonary artery pressure. That's class 1. For medical therapy in patients with rheumatic MS and atrial fibrillation or prior embolic event or LA thrombus, anticoagulation with vitamin K antagonist is indicated. That's class 1. In patients with rheumatic MS and atrial fibrillation with a rapid ventricular response, heart rate control can be beneficial. That's class 2A. In patients with rheumatic MS in normal sinus rhythm with symptomatic resting or exertional sinus tachy, heart rate control can be beneficial to manage these symptoms. That's class 2A as well. For intervention for patients with rheumatic MS, in symptomatic patients with NIHA class 2, 3, or 4, severe rheumatic MS, mitral valve area being equal or less than 1.5 centimeters square, so stage D, and favorable valve morphology with less than moderate MR plus 2. In the absence of LA thrombus, the percutaneous mitral balloon commissurotomy is recommended if it can be performed at a comprehensive valve center. That's a class 1 recommendation. In severely symptomatic patients with severe rheumatic MS, mitral valve area equal or less, who are not standard percutaneous commissurotomy or have failed previous percutaneous mitral balloon commissurotomy or require other cardiac procedures or don't have access to percutaneous intervention. Mitral valve surgery with repair, commissurotomy, or valve replacement is indicated as a class 1 level B. In asymptomatic patients with severe rheumatic MS with mitral valve area less than or equal to 1.5 and favorable valve morphology with less than +2 MR in the absence of LA thrombus who have elevated pulmonary pressure, pulmonary artery systolic pressure being more than 50, then percutaneous mitral balloon commissurotomy is reasonable if it can be performed at comprehensive valve center. It's a class 2A. This statement is new in the latest guidelines. For asymptomatic patients with severe rheumatic MS, mitral valve area less than or equal to 1.5 and favorable valve morphology with less than +2 MR and absence of LA thrombus who have new onset AF, percutaneous mitral balloon commissurotomy may be considered if it can be performed at a comprehensive valve center, that's class 2B, level C. For symptomatic patients with rheumatic MS and mitral valve area more than 1.5 centimeters square, if there is evidence of hemodynamic significant rheumatic MS on the basis of a pulmonary artery wedge pressure more than 25 millimeter mercury or a mean mitral valve gradient more than 15, during exercise, percutaneous mitral balloon commissurotomy may be considered if it can be performed at a comprehensive valve center. That's a class 2B as well. In severely symptomatic patients with severe rheumatic MS who have a suboptimal valve anatomy and who are not a candidate for surgery or at high risk for surgery, percutaneous mitral balloon commissurotomy may be considered if it can be performed at a comprehensive valve center. It's class 2B as well. This diagram just to summarize the recommendation for rheumatic MS intervention. As we can see here, there's no more very severe MS as like before in 2017 modified guidelines. And this statement is new for severe asymptomatic stage C rheumatic MS when we have favorable valve morphology with elevated pulmonary artery systolic pressure more than 50. It's a class 2A to go with percutaneous mitral balloon commissurotomy. For non-rheumatic calcific MS in severely symptomatic patients with severe MS and attributable to extensive MAC, valve intervention may be considered only after discussion of the high procedural risk and the individual patient's preference and values. That's class 2B. Moving to mitral regurg. Talking about stages of chronic primary MR first. As we said before, we have 4 stages. Stage A, chronic primary MR, when we have mild mitral valve prolapse with normal coaptation, with mild valve thickening and leaflet restriction. That will lead to no MR jet or small central jet area, less than 20% of LA volume on Doppler, and small vena contracta less than 0.3 centimeter, with no hemodynamic consequences and no symptoms. For stage B, chronic primary MR, we have moderate to severe mitral valve prolapse with normal coaptation and rheumatic valve changes with leaflet restriction and loss of central coaptation and history of prior infective endocarditis. For the valve hemodynamics, usually you have central jet MR 20 to 40% of LA or late systolic eccentric jet MR, vena contracta less than 0.7 centimeter and regurgitant volume less than 60 ml and regurgitant fraction less than 50% and airway of less than 0.4 centimeter square and angiographic grade of +1 to +2 MR, usually with mild LA enlargement, no LV enlargement, and normal pulmonary pressure and no symptoms. For stage C, asymptomatic severe MR, chronic primary MR, we have severe mitral valve prolapse with loss of coarctation or flail leaflet, rheumatic valve changes with leaflet restriction and loss of central coarctation prior infective endocarditis, or thickening of the leaflets with radiation heart disease. The JET usually contribute to more than 40% of LA or holosystolic eccentric jet MR. Vena contracta equals to or more than 0.7 centimeter. Regurgitant volume equal or more than 60 ml. Regurgitant fraction equals or more than 50%, and effective regurgitant orifice area of equal to or more than 0.4 centimeter square, and angiographic grading for the MR +3 to +4. That will lead to moderate or severe LA enlargement, LV enlargement. Pulmonary hypertension may be present at rest or with exercise, unlike the stage D. So stage C1, when we have the compensated ventricle with ejection fraction more than 60% and LV in systolic dimension less than 40 millimeter. Stage C2, when we have decompensated ventricle with left ventricular ejection fraction equal or less than 60% and or left ventricular in systolic dimension equals or more than 40 millimeter with no symptoms. For stage D symptomatic severe MR, we have severe mitral valve prolapse with loss of coarctation and flail leaflet, with rheumatic valve changes with leaflet restriction and loss of central coarctation, prior infective endocarditis, and thickening of leaflet with radiation heart disease as well. The central jet of MR will compromise more than 40% of LA volume or holosystolic eccentric jet MR. Vena contracta equals or more than 0.7. Regurgitant volume equals or more than 60 ml. Regurgitant fraction equals or more than 50%. ERWA equals or more than 0.4 centimeter square, and angiographic grading +3 to +4 MR. We will have moderate to severe LA enlargement, LV enlargement, and pulmonary hypertension present at rest and with exercise. And will have decreased exercise tolerance, exertional dyspnea. For initial diagnosis of chronic primary MR, in patients with known or suspected primary MR, transthoracic echo is indicated for baseline evaluation of LV size and function, and RV function, LA size, pulmonary artery pressure, and the mechanism and severity of primary MR from stage 1 to D. That's a class 1 recommendation. In patients with primary MR, when a transthoracic echo provides insufficient or discordant information, transesophageal echo is indicated for evaluation of the severity of MR, mechanism of MR, and status of LV function. That's a class 1 recommendation. In patients with primary MR, cardiac MRI is indicated to assess LV and RV volumes and function, and may help with assessing MR severity, where there is a discrepancy between the findings on clinical assessment and echo. That's a class 1 to go with cardiac MRI. In patients with severe primary MR undergoing mitral intervention, intraoperative TE is indicated to establish the anatomic basis for primary MR and to guide the repair. That's a class 1 recommendation as well. For frequency of testing, in case of changing signs or symptoms. In patients with primary MR and new onset or changing symptoms, transthoracic echo is indicated to evaluate the mitral valve apparatus and LV function. That's class 1 level B. For routine follow-up for patients with chronic primary MR in the asymptomatic stage with severe primary MR, stage B and C1, transthoracic echo is indicated every 6 to 12 months for surveillance of LV function estimated by left ventricular ejection fraction and end systolic and end diastolic dimension, and assessment of pulmonary artery pressure. That's a class 1 level B recommendation. In asymptomatic patients with severe primary MR, stages P and C1, use of serum biomarkers and novel measurements of LV function like a global longitudinal strain may be considered as an adjunct to guide the timing of an intervention. That's a class 2B, and this statement is new in the latest guidelines. Exercise testing for patients with chronic primary MR, stage B and C, and symptoms that might be attributable to MR, hemodynamic exercise testing using Doppler echo or cardiac cath, or cardiopulmonary exercise testing is reasonable as a class 2A level B. In asymptomatic or asymptomatic patients with severe primary MR and LV systolic dysfunction, stages C2 and D, in whom surgery is not possible or must be delayed, guideline-directed medical therapy for systolic dysfunction is reasonable, class 2A. But in asymptomatic patients with primary MR and normal LV, vasodilator therapy is not indicated if the patient is normotensive. That's class 3 with no benefit of such intervention. Usually the role of vasodilator therapy for acute MR, not for chronic MR. Intervention for patients with chronic primary MR. It's a class 1 recommendation for symptomatic patients with severe primary MR to go with mitral valve intervention irrespective of LV systolic function. That's a new statement also, adding irrespective of LV systolic function. It's a class 1. In asymptomatic patients with severe primary MR and LV systolic dysfunction with ejection fraction equals or less than 60% and end systolic dimension equals or more than 40, stage C2, mitral valve surgery is recommended as a class 1 level B recommendation. In patients with severe primary MR for whom surgery is indicated, mitral valve repair is recommended in preference to mitral valve replacement when the anatomic cause of MR is degenerative disease and if a successful and durable repair is possible as a class 1 level B recommendation. In asymptomatic patients with severe primary MR and normal LV systolic function, stage C1, mitral valve repair is reasonable when the likelihood of a successful and durable repair without a residual MR is more than 95% with an expected mortality rate of less than 1% when it can be performed at a primary or a comprehensive valve center. That's a class 2A. So the residual MR it has to be more than the durability more than 95% and expected mortality less than 1%. That's new in the latest guidelines. In asymptomatic patients with severe primary MR and normal LV systolic function, but with progressive increase in LV size or decrease in ejection fraction on 3 or more serial imaging studies, mitral valve surgery may be considered irrespective of the probability of a successful and durable repair. That's a class 2B recommendation. The statement is new as well. In severely symptomatic patients, NIHA class 3 or 4, with primary severe MR and high or prohibitive surgical risk, transcatheter edge-to-edge repair is reasonable if mitral valve anatomy is favorable for the repair procedure and the patient life expectancy is at least 1 year. That's a class 2A. In symptomatic patients with severe primary MR attributable to rheumatic valve disease, mitral valve repair may be considered at a comprehensive valve center by an experienced team when surgical treatment is indicated and if a durable and successful repair is likely, class 2B. In patients with severe primary MR, where the leaflet's pathology is limited to less than 1/2 of the posterior leaflet and mitral valve replacement should not be performed unless mitral valve repair has been attempted at a primary or a comprehensive valve center and was unsuccessful, class 3. This diagram, just to summarize the recommendation for intervention in case of a chronic primary MR with comparison to the previous 2017 modified guidelines. As we can see here, for severe symptomatic chronic primary MR, regardless of LV function, that's a new statement. And if the patient will go for surgery, but with high or prohibitive surgical risk with anatomy favorable for transcatheter repair, it's a class 2A to go for transcatheter edge-to-edge repair. This is a new as well. And we don't have here, in case of stage C asymptomatic chronic primary MR, the new onset AF or pulmonary artery systolic pressure is no longer in the new guidelines. I think the trend is toward early repair, and you should not wait till development of new onset AF or high pulmonary artery systolic pressure, because it's a turning point in patient symptoms. Moving to secondary MR, we have 4 stages as well. Stage A, when the patient at risk of MR with normal valve leaflets, cords, and annulus in patients with coronary artery disease or cardiomyopathy, with valve hemodynamics, no MR jet or small central jet, less than 20% of LA volume in Doppler, and small vena contracta less than 0.3 centimeter, with normal or mildly dilated LV size with fixed infarction or inducible ischemia, regional wall motion abnormalities, primary myocardial disease with LV dilatation and systolic dysfunction, and the symptoms usually attributable to coronary ischemia or heart failure that may present and will respond to revascularization and appropriate medical therapy. Stage B, progressive secondary MR. Usually we have regional wall motion abnormalities with mild tethering of mitral leaflet and annular dilatation with mild loss of central coaptation of the mitral leaflets. For valve hemodynamics, the effective regurgitant orifice area will be less than 0.4 centimeter square, and the regurgitant volume less than 60 ml and regurgitant fraction less than 50%. The associated cardiac findings, usually we have regional wall motion abnormalities with reduced LV systolic function and LV dilatation and systolic dysfunction attributable to primary myocardial disease, and the symptoms also attributable to coronary ischemia and heart failure that may respond to revascularization or appropriate medical therapy. Stage C for asymptomatic severe chronic secondary MR will have regional wall motion abnormalities and or LV dilatation with severe tethering of the mitral leaflets and annular dilatation with severe loss of central coaptation of the mitral leaflets. For valve hemodynamics, the effective regurgitant orifice area will be equal or more than 0.4 centimeter, and the regurgitant volume equal or more than 60 ml, and the regurgitant fraction equals or more than 50%. So same like in the primary MR, same cutoff points, unlike the European guidelines. For regional wall motion abnormalities, might present with a reduced LV systolic function and LV dilatation and systolic dysfunction attributable to primary myocardial disease, and the symptoms usually due to a coronary ischemia or heart failure that may respond to appropriate intervention. For stage D symptomatic severe secondary MR, will have regional wall motion abnormalities and oral LV dilatation and severe tethering of mitral valve leaflets, annular dilatation with severe loss of central cohabitation of the mitral leaflets. The effective regurgitant orifice area will be equal or more than 0.4 centimeter square, with regurgitant volume equal or more than 60 ml, and the regurgitant fraction of 50% or more. The associated cardiac findings, like before, regional wall motion abnormalities and reduced LV systolic function, LV dilatation and systolic dysfunction attributable to primary myocardial disease. For the symptoms in stage D chronic secondary MR, the heart failure symptoms attributable to MR persist even after revascularization or optimization of medical therapy. Patients will have decreased exercise tolerance and exertional dyspnea. Moving to diagnosis of secondary MR. In patients with chronic secondary MR, stage B to D, transthoracic echo is useful to establish the etiology, assess the extent of regional and global LV remodeling, and systolic dysfunction, severity of MR, and magnitude of pulmonary hypertension, class 1 level B. In patients with chronic secondary MR, stages B to D, the non-invasive imaging with stress, nuclear, PET scan, cardiac MRI, or stress echo, coronary CT angio, or coronary arteriography is useful to establish the etiology of MR and to assess the myocardial viability. It's a class 1. In patients with chronic secondary MR with severe symptoms, stage D, that are unresponsive to guideline-directed medical therapy, who are being considered for transcatheter mitral valve interventions, transesophageal echo is indicated to determine the suitability for the procedure. It's a class 1 level P. In patients with chronic secondary MR undergoing transcatheter mitral valve intervention, intraprocedural guidance with TEE is recommended as a class 1 level C. For medical therapy in patients with secondary MR, patients with chronic severe secondary MR stages C and D and heart failure with reduced ejection fraction should receive standard guideline-directed medical therapy for heart failure, including ACE and ARBs, beta blockers, aldosterone antagonists, and or sacubitril valsartan combination, and biventricular pacing as indicated. This combination from Arni group, it was added in the latest guidelines as a class 1. In patients with chronic severe secondary MR and heart failure with reduced ejection fraction, a cardiologist expert in the management of patients with heart failure and LV systolic dysfunction should be the primary multidisciplinary team member responsible for the implementing and monitoring optimal guideline-directed medical therapy as a class 1 recommendation. Moving to intervention for patients with secondary MR. In case of chronic severe secondary MR related to LV systolic dysfunction, ejection fraction less than 50%, who have persistent symptoms, NIHA class 2, 3, 4, while on optimal guideline-directed medical therapy for heart failure, transcatheter edge-to-edge repair, is reasonable in patients with appropriate anatomy as defined on transesophageal echo and with left ventricle ejection fraction between 20 and 50%, left ventricular insystolic dimension less than or equal to 70 millimeter, and pulmonary arterial systolic pressure less than or equal to 70 millimeter mercury. It's a class 2A, and that was driven by the result of the QUAD trial, which was published in 2018. In patients with severe secondary MR, stages C and D, mitral valve surgery is reasonable when CABG is undertaken for the treatment of myocardial ischemia. It's a class 2A. In patients with chronic severe secondary MR from atrial annular dilatation with preserved LV systolic function equals or more than 50%, who have severe persistent symptoms, NIHA class 3 or 4, despite therapy for heart failure and therapy for associated atrial fibrillation or other comorbidities, mitral valve surgery may be considered as a class 2B. In patients with chronic severe secondary MR related to LV systolic dysfunction, less than 50%, who have persistent severe symptoms while on optimal medical therapy for heart failure, mitral valve surgery may be considered as a class 2P. In patients with coronary artery disease and chronic severe secondary MR related to LV systolic dysfunction, who are undergoing mitral valve surgery because of severe symptoms that persist despite medical therapy for heart failure, chordal sparing mitral valve replacement may be reasonable to choose over downsized annuloplasty repair as a class 2B level B. So to summarize, the secondary chronic MR recommendation for intervention as compared to the 2017 guidelines. If the patient is severely symptomatic with reduced ejection fraction, favorable valve anatomy, and meeting the criteria of left ventricular ejection fraction 20 to 50%, and insystolic dimension equals or less than 70 millimeter, and pulmonary artery systolic pressure less than or equal to 70 millimeter mercury. Same criteria used in a co-op trial. It's a class 2A to go with transcatheter repair. That's new in the newest guidelines. For diagnosis and follow-up of patients with prosthetic valves, in patients with a surgical or transcatheter prosthetic valve and in patients who have had valve repair, initial post-operative transthoracic echo is recommended for evaluation of valve hemodynamics and ventricular function. It's a class 1. And in patients with a prosthetic valve or prior valve repair and a change in clinical symptoms or signs suggesting valve dysfunction, repeat transthoracic echo is recommended as a class 1. In patients with prosthetic valve replacement or prior valve repair and clinical symptoms or signs that suggest prosthetic valve dysfunction, additional imaging with transesophageal echo, gated cardiac CT, or fluoroscopy is recommended, even if the transthoracic echo does not show a valve dysfunction. It's a class 1. In patients with a bioprosthetic surgical valve, transthoracic echo at 5 and 10 years, and then annually after implantation is reasonable even in the absence of a change in clinical status. It's a class 2A. For a prosthetic valve type, bioprosthesis versus mechanical, in patients who require heart valve replacement, the choice of prosthetic valve should be based on a shared decision-making process that accounts for patients' values and preferences and includes discussion of the indications for the risk, of anticoagulation therapy and the potential need and the risk for associated valve re-intervention. It's a class 1. For patients of any age requiring valve replacement for whom anticoagulant therapy is contraindicated, cannot be managed appropriately, or is not desired, the bioprosthetic valve is recommended as a class 1. For patients less than 65 years of age who have an indication for mitral valve replacement, do not have a contraindication to anticoagulation, and are unable to undergo mitral valve repair, it's reasonable to choose a mechanical mitral prosthesis over a bioprosthetic valve. It used to be 70 years, and the newest guidelines less than 65. For patients equals or more than 65 years of age who require mitral valve replacement and are unable to undergo mitral valve repair, it's reasonable to choose a bioprosthesis over a mechanical valve as a class 2A recommendation. This is just a summary for prosthetic valve requiring intervention. So the cutoffs were changed in the newest guidelines, and more detail in the aortic valve. So some factors that favors mechanical versus bioprosthetic valve: age being less than 50 years, increased incidence of structural deterioration with bioprosthesis, being 15-year risk of 30% for age of 40 year and 15% for age of 20 year. So it's obviously that's younger age at surgical intervention will increase the risk of bioprosthetic structural deterioration. Lower risk of anticoagulation complication. Patient's preference, low risk of long-term anticoagulation, compliant patient with either home monitoring or close access to INR monitoring, other indication for long-term anticoagulation like AF, and high-risk re-intervention like porcelain aorta prior radiation therapy. Factors that favor bioprosthesis: age more than 65, low incidence of structural deterioration, and higher risk of anticoagulation complications, patient preference, and high risk of long-term anticoagulation, limited access to medical care, and access to surgical centers with low reoperation mortality rate, access to transcatheter valve and valve replacement. For antithrombotic therapy for prosthetic valve guidelines, in patients with a mechanical prosthetic valve, anticoagulation with a vitamin K antagonist is recommended as a class 1. And for patients with a mechanical mitral valve replacement, anticoagulation with a vitamin K antagonist is indicated to achieve an INR of 3 as a class 1. For all patients with a bioprosthetic surgical AVR or mitral valve replacement, aspirin 75 to 100 milligram daily is reasonable in the absence of other indications for oral anticoagulations as a class 2A. For patients with a bioprosthetic surgical AVR or mitral valve replacement who are at low risk of bleeding, anticoagulation with a vitamin K antagonist to achieve an INR of 2.5 is reasonable at least 3 months, and for as long as 6 months after surgical replacement, it's a class 2A to anticoagulate them. For patients with a mechanical surgical AVR or mitral valve replacement who are managed with a vitamin K antagonist and have an indication for antiplatelet therapy, addition of aspirin 75 to 100 milligram daily may be considered when the risk of bleeding is low as a class 2P. But for patients with a mechanical valve prosthesis, anticoagulation with the direct thrombin inhibitor, dabigatran, is contraindicated, class 3. And for patients with a mechanical valve prosthesis, the use of the newer generation anti-factor 10 direct oral anticoagulants has not been assessed and it's not recommended as well. It's a class 3. This is just to summarize bioprosthetic versus a mechanical valve anticoagulation management. For bridging, in patients with mechanical heart valves who are undergoing minor procedure like dental extractions or cataract removal, where bleeding is easily controlled, continuation of vitamin K antagonist anticoagulation with a therapeutic INR is recommended as a class 1. But for patients with a mechanical valve prosthesis receiving a vitamin K antagonist therapy who require immediate or emergency non-cardiac surgery or an invasive procedure, administration of a 4-factor prothrombin complex concentrate or its activated form is reasonable as a class 2A in case of immediate or emergency. For patients with a bioprosthetic heart valves or annuloplasty rings who are receiving anticoagulation for AF, it's reasonable to consider the need for bridging anticoagulant therapy around the time of 4 invasive procedures on the basis of CHA2DS2-VASc score weighted against the risk of bleeding as a class 2A. And for patients who are undergoing invasive procedure and have mechanical AVR and thromboembolic risk factors, older generation mechanical AVR, mechanical MVR, bridging anticoagulation therapy during the preoperative time when the INR is subtherapeutic, it's reasonable on an individualized basis with the risk of bleeding weighted against the benefit of thromboembolism prevention as a class 2A. For management of excessive anticoagulation and serious bleeding in patients with prosthetic valves, for patients with a mechanical valve and uncontrollable bleeding who require immediate reversal of anticoagulation, administration of 4-factor prothrombin complex or the activated form is reasonable as a class 2A. And for patients with mechanical valve and uncontrollable bleeding who have received already the 4-factor prothrombin concentrate complex, adjunctive use of intravenous vitamin K is reasonable if the resumption of vitamin K antagonist therapy is not anticipated for 7 days as a class 2A. For patients with a bioprosthetic valves or annuloplasty rings who are receiving a direct oral anticoagulant and who require immediate reversal of anticoagulation because of uncontrollable bleeding, treatment with idarucizumab for dabigatran reversal or andexanet alpha for reversal of anti-factor 10 agents is reasonable as a class 2A. For patients with a mechanical prosthetic valves and supratherapeutic INR more than 5 who are actively bleeding, the benefit of individualized treatment with oral vitamin K in addition to temporary withdrawal of vitamin K antagonists is uncertain, class 2B. But for patients with mechanical MVR replacement who experience a stroke or systemic embolic event while in therapeutic range of vitamin K antagonist anticoagulation, it's reasonable to increase the INR goal from 3 to 4, ranges from 3.5 to 4, or to add a daily low-dose aspirin with assessment of bleeding risk as a class 2A, and in patients with a bioprosthetic surgical or transcatheter aortic valve or bioprosthetic mitral valve who experience a stroke or systemic embolic event while on antiplatelet therapy, vitamin K antagonist anticoagulant instead of antiplatelet therapy may be considered after assessment of bleeding risk as a class 2B. This is just a summary for management of embolic events and valve thrombosis. For diagnosis of acute mechanical valve thrombosis, it's recommended that with suspected mechanical prosthesis valve thrombosis to go with urgent transthoracic echo, transesophageal echo, fluoroscopy, or a multi-detector CT imaging to assess valve function, leaflet motion, and the presence and extent of thrombus, as a class 1. And for patients with a thrombosed left-sided mechanical prosthesis, heart valve, or who present with symptoms of valve obstruction, urgent initial treatment with either slow infusion or low-dose fibrinolytic therapy or emergency surgery is recommended as a class 1. Factors that favor surgery versus fibrinolytic therapy in case of prosthetic valve thrombosis: readily available surgical expertise, low surgical risk, contraindication to fibrinolytic therapy, recurrent valve thrombosis, NIHA class 4, large clot more than 0.8 centimeters square, presence of LA thrombus, concomitant coronary artery disease, which need revascularization, and other valve disease, possible PANAS formation, and patient choice. Factors that favor fibrinolytic therapy over surgery when we have no surgical expertise available, high surgical risk, no contraindication to fibrinolytic therapy, first time episode of valve thrombosis, NIHA class 1, 2, 3, small clots or no LA thrombus, no or mild coronary artery disease, no other valve disease, thrombus is visualized, and patient choice, of course. For patients with suspected bioprosthetic valve thrombosis, a 3D transesophageal echo or 4D CT imaging can be useful to rule out leaflet thrombosis as a class 2A. And in patients with suspected or confirmed bioprosthetic valve thrombosis who are hemodynamically stable and have no contraindication to anticoagulation, initial treatment with a vitamin K antagonist is reasonable as a class 2A. For patients with suspected mechanical or bioprosthetic valve stenosis, a transthoracic and transesophageal echo are recommended to diagnose the cause and severity of valve obstruction, assess ventricular function, and estimate pulmonary artery systolic pressure as a class 1A. In patients with mechanical valve stenosis, fluoroscopy or science CT is recommended to assess motion of the mechanical valve leaflets as a class 1, level C. In patients with bioprosthetic valve stenosis, a 3D transesophageal echo or 4D CT imaging can be useful to rule out leaflet thrombosis as a class 2A level C. When to intervene for patients with prosthetic valve stenosis. In patients with symptomatic severe stenosis of a bioprosthetic or mechanical valve, repeat surgical intervention is indicated unless surgical risk is high or prohibitive, this is class 1. For severely symptomatic patients with bioprosthetic aortic valve stenosis and high or prohibitive surgical risk, a transcatheter valve-in-valve procedure is reasonable when performed at a comprehensive valve center. It's a class 2A. For patients with a significant bioprosthetic valve stenosis attributable to a suspected or documented valve thrombosis, oral anticoagulation with a vitamin K antagonist is reasonable as a class 2A. For prosthetic valve rigueur, in patients with suspected mechanical or bioprosthetic valve rigueur, transthoracic. Yes.
If it's okay with you, can we have just a quick break for 5 minutes?
Yes, sure.
Just for people to refresh it. So we'll come back after 5 minutes. Thank you.
Thank you.
دكتور خالد.
أي نعم.
تفضل.
So continuing with diagnosis of prosthetic valve regurg, it's recommended in case of suspicion of mechanical or bioprosthetic valve regurg to go with transthoracic or transesophageal echo to determine the cause and severity of the leak, assess ventricular function, and estimate pulmonary artery systolic pressure. As a class 1, in patients undergoing a transcatheter procedure for a paravalvular prosthetic regurg, 3D transesophageal echo is recommended for intra-procedural guidance as a class 1. So intervention for a prosthetic valve regurg in patient with intractable hemolysis or heart failure attributable to prosthetic transvalvular or paravalvular leak, surgery is recommended unless surgical risk is high or prohibitive as a class 1. In asymptomatic patients with severe prosthetic regurg and low operative risk, surgery is reasonable as a class 2A level B. In patients with prosthetic paravalvular regurg with the following, either intractable hemolysis or NIHA class 3 to 4, who are at high risk or prohibitive surgical risk, have anatomic features suitable for catheter-based therapy, percutaneous repair of paravalvular leak is reasonable when they performed procedure at a comprehensive valve center as a class 2A. Same in prosthetic valve stenosis. For patients with severe heart failure symptoms caused by a bioprosthetic valve regurg who are at high or prohibitive surgical risk, a transcatheter valve-in-valve procedure is reasonable when performed at a comprehensive valve center as a class 2A. And this diagram summarizes the recommendation for a prosthetic valve, either stenosis or regurg, and how to approach them from diagnosis to intervention. Moving to pregnancy and valvular heart disease issues. For the initial management of women with a valvular heart disease before and during pregnancy, it's recommended that when suspected for a valve disease who are considering pregnancy should undergo a clinical evaluation and a transthoracic echo before pregnancy as a class 1. And for women with severe valve disease stages C and D who are considering pregnancy should undergo pre-pregnancy counseling by a cardiologist with expertise in managing women with valvular heart disease during pregnancy as a class 1 as well. And for pregnant women with severe valve disease stages C and D should be monitored in a tertiary care center with a dedicated heart valve team of a cardiologist, a surgeon, anesthesiologist, and a maternal fetal medicine obstetrician with expertise in the management of high-risk cardiac conditions during pregnancy as a class 1. And for asymptomatic women with severe valve disease stages C1 who are considering pregnancy, exercise testing is reasonable before pregnancy for risk assessment as a class 2A. Moving to medical therapy for pregnant women with valvular heart disease. In pregnant women with valvular heart disease, beta blocker medications are reasonable as required for heart rate control or treatment of arrhythmia as a class 2A. And in pregnant women with valvular heart disease and heart failure symptoms, stage D, diuretic medication are reasonable if needed for volume overload. It's a class 2A. But in pregnant women with valvular heart disease, ACE and ARB should not be given because of fetal risk. It's a class 3 because it does cross the placenta. For pre-pregnancy intervention in women with valvular heart disease, in symptomatic women with severe valvular heart disease who are considering pregnancy, intervention before pregnancy is recommended on the basis of standard indication as a class 1. In women who require a valve intervention before pregnancy, the choice of prosthetic valve should be based on a shared decision-making process that accounts for the patient's values and preferences, including discussion of the risk of mechanical valves during pregnancy and the reduced durability of bioprosthetic valves in young women as a class 1. For asymptomatic women with severe rheumatic MS, mitral valve area equals or less than 1.5 centimeters square, stage C1, who are considering pregnancy, a percutaneous mitral balloon commissurotomy at a comprehensive valve center is reasonable before pregnancy for those who have favorable valve morphology as a class 2A. In women of childbearing age who require a valve replacement, a bioprosthetic valve are preferred over mechanical valves because of the increased maternal and fetal risk of mechanical heart valve in pregnancy as a class 2A. And in asymptomatic women with severe MR stage C1 and a valve suitable for repair who are considering pregnancy, a valve repair before pregnancy at a comprehensive valve center may be considered, but only after detailed discussion with the patient about the risk and benefit of the surgery and its effect on future pregnancies as a class 2B. For intervention during pregnancy in women with valvular heart disease, in case of severe rheumatic MS with mitral valve area equals or less than 1.5, stage D, with valve morphology favorable for percutaneous repair, who remain symptomatic with NIHA class 3 or 4 heart failure symptoms despite medical therapy. Percutaneous mitral balloon commissurotomy is reasonable during pregnancy if it's performed at comprehensive valve center that's a class 2A. And for pregnant women with severe valve regurg with NIHA class 4 heart failure symptoms, refractory to medical therapy, valve surgery is reasonable during pregnancy. It's a class 2A. And in pregnant women with valvular heart disease, a valve surgery should not be performed in the absence of severe heart failure symptoms refractory to medical therapy. It's a class 3. For management of prosthetic heart valves in pregnant women, women with a prosthetic valve should undergo pre-pregnancy assessment, including echo by a cardiologist, with expertise in managing women with valvular heart disease during pregnancy. It's class 1. Pregnant women with a mechanical prosthesis should be monitored in a tertiary care center with a dedicated multidisciplinary team of a cardiologist, surgeons, and anesthesiologists, maternal fetal medicine obstetricians with expertise in the management of high-risk cardiac conditions during pregnancy. It's a class 1. For women with mechanical heart valves considering pregnancy should be counseled that pregnancy is high risk and that there is no anticoagulation strategy that's consistently safe for the mother and baby. It's a class 1. Pregnant women with a mechanical prosthetic valve who have prosthetic valve obstruction or experience an embolic event should undergo a transesophageal echo as a class 1. For anticoagulation for pregnant women with mechanical prosthetic valve, pregnant women with mechanical prosthesis should receive a therapeutic anticoagulation with frequent monitoring during pregnancy. It's a class 1. Women with mechanical heart valves who cannot maintain a therapeutic anticoagulation with frequent monitoring should be counseled against pregnancy. It's a class 1. Women with mechanical heart valves and their providers should use shared decision making to choose anticoagulation strategy for pregnancy, and women should be informed that vitamin K antagonist during pregnancy is associated with the lowest likelihood of maternal complications, but the highest likelihood of miscarriages, fetal death, and congenital abnormalities, particularly if taken during the first trimester and if the warfarin dose exceeded 5 milligrams per day. It's a class 1. For pregnant women with mechanical valve prosthesis who are on warfarin, should switch to twice daily low molecular weight heparin with target anti-10A level of 0.8 units per ml to 1.2 units per ml at 4 to 6 hours after dose, or intravenous unfractionated heparin with an activated partial thromboplastin time, 2 times the control, at least 1 week before planned delivery. It's a class 1. And for pregnant women with a mechanical valve prosthesis who are on low molecular weight heparin should switch to unfractionated heparin at least 36 hours before planned delivery. It's a class 1. And for pregnant women with valve prosthesis should stop the unfractionated heparin at least 6 hours before a planned vaginal delivery. It's a class 1. And if labor begins or urgent delivery is required, in a woman therapeutically anticoagulated with a vitamin K antagonist, a cesarean section should be performed after reversal of anticoagulation. That's the class 1. For women with mechanical prosthesis who require a dose of warfarin equals or less than 5 milligram per day to maintain a therapeutic INR, continuation of warfarin for all 3 trimesters is reasonable after full discussion with the patient about risk and benefits. It's a class 2A. And for pregnant women with mechanical prosthesis who require more than 5 milligram per day of warfarin to achieve a therapeutic INR, a dose-adjusted low molecular weight heparin with targeted anti-10A level, checked after 4 to 6 hours after dose, at least 2 times per day during the first trimester, followed by warfarin during the second and third trimester is reasonable strategy as a class 2A. And for pregnant women with a mechanical prosthesis who require a dose of warfarin more than 5 milligram per day to achieve a therapeutic INR, and for whom dose-adjusted low molecular weight heparin is unavailable, or dose-adjusted continuous intravenous antifractionated heparin during the first trimester with targeted ABTT 2 times the control, followed by warfarin for the second and third trimester. That's another reasonable strategy as well with class 2A recommendation. For hemodynamically stable pregnant women with obstructive left-sided mechanical valve thrombosis, that's reasonable to manage with slow infusion, low-dose fibrinolytic therapy as a class 2A. And for pregnant women with mechanical prosthesis who require warfarin dose more than 5 a day to achieve a therapeutic INR, a dose-adjusted low molecular weight heparin at least 2 times per day for all 3 trimesters may be considered as a class 2B. And for pregnant women with a mechanical prosthesis who require a dose of warfarin equals or less than 5 milligram per day to maintain a therapeutic INR, a dose-adjusted low molecular weight heparin at least 2 times a day during the first trimester, followed by warfarin for the second and third trimesters, may be considered as a class 2B. And for pregnant women with mechanical prosthesis, aspirin, low-dose aspirin, 75 to 100 milligram daily may be considered in addition to anticoagulation. That's a class 2B. And for pregnant women with mechanical prosthesis, low molecular weight heparin should not be administered unless anti-10A levels are monitored 4 to 6 hours after administration, and dose is adjusted according to levels. It's a class 3. And for patients with mechanical valve prosthesis, anticoagulation with the direct thrombin inhibitor, dabigatran should not be administered, the class 3 as well. And the use of anti-10A direct oral anticoagulant therapy for mechanical heart valves in pregnancy has not been assessed and is not recommended as well as a class 3. This is a summary for anticoagulation for prosthetic valve in a woman during pregnancy. Moving to some surgical considerations in case of management of coronary artery disease in patient undergoing a valve surgery. In patients with symptoms of angina, objective evidence of ischemia, decreased LV systolic function, history of coronary artery disease, or coronary risk score, including men more than 40 years of age and postmenopausal women, Invasive coronary angio is indicated before valve intervention, that's class 1. In patients with severe secondary MR, invasive coronary angio should be performed as a part of for the evaluation, it's a class 1. But in selected patients with a low to intermediate pretest probability for coronary artery disease, contrast, CT angio is reasonable to exclude the presence of significant obstructive coronary artery disease, that's class 2A, in low to intermediate risk. In patients undergoing a valve repair or replacement with significant proximal coronary artery disease, 70 or more reduction in luminal diameter in major coronary arteries, or 50% or more reduction in luminal diameter in the left main, and or physiological significance, coverage is reasonable for selective patients as a class 2A. So if patient will undergo a valve surgery, low intermediate risk, CT angio. If the case is chronic severe secondary MR, coronary angio is class 1, and symptomatic patient, documented high risk for coronary artery disease, it's a class 1 also to go for coronary angio. And if there is significant proximal coronary artery disease or left main disease, it's a class 2A to go with coverage. For a non-cardiac surgery in patients with valvular heart disease, if clinically suspected moderate or greater degrees of valvular stenosis or regurg who are undergoing a non-cardiac surgery, preoperative echo is recommended as a class 1. And in patients who meet the standard indication for intervention for valvular heart disease, whether replacement or repair, on the basis of symptoms and disease severity, intervention should be performed before the elective non-cardiac surgery to reduce the perioperative risk if possible, depending on the urgency and risk of non-cardiac procedure as a class 1. And lastly, management of asymptomatic patients with valvular heart disease undergoing non-cardiac surgery. It's recommended that in asymptomatic patients with a moderate or greater degree of rheumatic MS with less than severe pulmonary hypertension, pulmonary artery systolic pressure less than 50, it's reasonable to perform elective non-cardiac surgery as a class 2A. And in asymptomatic patients with moderate or greater degree of MR and normal LV systolic function with less than severe pulmonary hypertension, it's reasonable to perform also the elective non-cardiac surgery as a class 2A level C recommendation. By this, I conclude my talk today about the latest 2020 American Heart guidelines for management of patients with mitral valve disease. And thank you.
Thank you, Khalid. Great effort and nice review.
Thank you.
Thank you, Dr. Khalid, for reviewing these guidelines. Any questions for? Sorry?
معاكم consultant؟
ما كان موجود دكتور حسن بس أتوقع أنه ما هو معنا حاليا.
سؤال للدكتور خالد. Have you memorized all this now? Can we ask you about anything by heart?
For the MS and MR guidelines, most of them, yes.
Okay, so if I test you on any of these pages, you can answer it without going back to it, صح?
Inshallah.
Okay, I tell you, I don't memorize it. I don't think anybody really memorize it. Those who are practicing it, maybe for one disease like the mitral valve or something, may know it all, but rarely you'll find somebody memorizing all these guidelines. One thing you have to know is that you have to be able to access it. You should have a clear idea about at least indications, class 1 indications, and when you should not operate, when it's harmful, do operate or give medications or change the type of anticoagulation, for example. That's my advice to you, to the rest of the group. Thank you.
Thank you, everybody.
من الناس اللي سووا عندهم خبرة في الامتحانات، في أحد يقدر يقول لنا if they ask you specifically about what class indication it is? Do they ask you this?
I mean MCQs دكتور ولا oral exams?
Be it oral or MCQ. I'm not sure if any of the seniors are here who have experienced that, but I think it's very unfair really to ask anybody to memorize this. And imagine you have something for the valves, something for the cabbages, something for the, and it usually comes in hundreds of pages, 200, 300 pages. So.
As you said, Doctor, maybe the class one and maybe the harmful when not to do the surgery are these the most important ones too.
Or a specific area of interest. If you're interested, for example, in the aortic valve, you should know it, yeah, because that will be your practice day in and day out.
Yeah.
I think it comes with the experience and time. I don't think it's something that we have to memorize يعني, by heart from now.
Even with experience, I tell you, I can grab any senior cardiac surgeon or cardiologist and ask him specifically about something. They will always have doubt about it. It's not, you have to know, it could be you could know everything about very small thing in the guidelines, maybe about, let's say, SAVR versus TAVR. They know it very well, okay? But beyond that, it's very difficult to grasp all the guidelines in your head. So it should not be a requirement. You should know how to access it. You should know how to look it up. You should know how to interact with it and things like this.
Okay, any other comment or question from Dr. Khalid? Okay, so for next week we have three lectures about mitral valve replacement by Dr. Zahra Idris, surgery for functional mitral regurg by Dr. Abdul Rahman Rouaili, and Journal Club to be